Hello and welcome. Now this talk is about discography, and it would essentially tell you how I do discography and why I do discography. The first thing is the position of the patient is prone, and we normally stand on the symptomatic side of the patient. We use a C-arm for getting fluoroscopic images of the spine in AP and lateral. The point of AP entry is determined initially by drawing a midline and a disc space as is seen in AP, and then in lateral we confirm the depth of the disc, which as we have mentioned before about 9.5, so we go about 3 more centimeters outside as to enter the disc. The lateral X-ray image or the fluoroscopy image also tells us about the inclination of the disc, which at 4, 5 and 5, 1 is towards the head, and at 2, 3, L1, 2 and D12, L1 is towards the leg. L3, 4 is generally vertical when the patient is lying prone. Then we use a radiopaque dye, or we can use a radiopaque dye plus indigo carmine or various other medicines. In some cases we use the dye as well as local anesthetic, which is a sodium channel blocker. And we can do discography. We can also do analgesic discography, that is using the local anesthetic as the injectate. We can also do discography with dye and indigo carmine, and many times we follow this with a CT or a MRI as to see in cross section what is changing in the disc, what is changing in the annulus, what is changing in the lateral part of the annulus, mainly in the annular tears. We can use anesthetic to find out whether the pain which is elicited by the discogram can be relieved by the use of lidocaine inside the disc. Sometimes we use steroid after we have finished the discogram, and nowadays we have started using a PRP or a PRF after the discography as to decrease the inflammation around the site of pain generation. Now this in short are the images which will clarify what we do. We are putting the patient prone, we mark the midline. Under fluoroscopy we take the disc space as is seen in AP. In lateral we measure the depth and then go towards the head with the inclination and mark the point above the line, which nowadays we have come to about 12.5 centimeters, which is the right point for entry for the surgery. For the injection or discogram you could always go at 9.5 centimeters from the midline. Now the needle goes paraspinal, intramuscular, below the facet, behind the psoas, behind the peritoneal sac, in the foramen. And when we inject, we note the volume of the injected, whether there is a response in the form of pain by the patient. We note the location of the pain, and we note whether it is concordant with what the patient talks about, whether the pain is same as what the patient normally experiences, meaning thereby that we are confirming the origin of the pain. Then we see the distribution of the dye, whether it remains inside the disc, whether it is a bilobar appearance of the nucleus, which is normal, whether there is a leak from the nucleus through the annular tear in the epidural space. And normally in a patient where there is a need to understand the origin of pain and which is not possible through the images alone, then we do a CT discography, that is after the discogram we ask the patient to go for CT, so that we confirm the location of the annular tear and how the disc is behaving and why it is behaving like that. There is a NAS, North American Spine Society, position statement about the indications of discography. Preoperatively, if there is a persistent pain where the disc abnormality is suspect, we are not very sure whether the disc is the cause. We feel clinically that the disc is the cause, but we are not very sure, in which case what we do is we do a discogram. Non-invasive images have not provided sufficient diagnostic information, then a discogram is essential. And then if we want the images to be correlated with the symptoms, we do discogram. Intraoperatively, if we are considering a disc for fusion, we do a discography as to confirm that the pain is really coming from the disc. And if we are considering one out of many segments for fusion, then we must do a discogram as to identify which amongst the many is the cause of the symptoms, especially if the adjacent disc is normal. And to confirm that the adjacent disc is normal, we do a discogram in that disc also. In case of post-operative status, If the previous surgery has not given significant relief of pain, there is a failure to relieve the pain and to differentiate between the recurrence of the disc herniation and a post-op scar, a discography may be done. These are the indications which are supported by North American Spine Society as a policy statement, and these are helpful in understanding the utility of the discography. Now, this is a modified Dallas discogram scale where the grade 0 is where the annulus and the nucleus is normal. In grade 1, there is annular tear which is at the beginning. In 2, the tear progresses to almost mid annulus. In 3, it goes to the posterior annulus, to the posterior posterolateral boundary of the annulus, but there are some layers of the annulus which are intact. And grade 4, the thing spreads just below the outer layer of the annulus, but here the nerve tissue starts getting involved, and there is a neurotization and vascular response which determines the symptom. And in grade 5, there is a break in the annular integrity, and the material inside, the nuclear material, starts coming out of the disc and starts giving the symptoms. So the same thing is seen here in the slide, which has been shown to us by Professor Rauschning, and this shows that there is a radial tear, there is granulation tissue here which can be seen in a enlarged view in this area, and this whole inflammatory thing involves the traversing nerve or the exiting nerve here and gives rise to problems, gives rise to symptoms. Now, there have been a lot of questions about the safety of the act and the utility and the content of the discogram. We have been using iodinated contrast, and then there are some people who react to this iodine content because they have an allergy to the iodine, in which case we should go in for use of gadolinium. A study in 2004 has concluded that no after effects of the discography as back pain or leg pain or loss of work, and more doctor visits are seen with a 4-year follow-up up to 2008. In 2009 publication, there were people who were studied initially in 1997. There were 75 patients, and they were followed up for 10 years, and there was a statistically significant difference in the control MRI and the disco plus MRI group. What had happened is the disc height and loss of signal was more seen in people who had undergone discography. 55 and 22, that is herniations in discogram on side of puncture, were 22 out of these people on the side of puncture. So maybe the puncturing of the annulus in the act of discogram may be weakening the annulus and maybe aiding the herniation of the nucleus over a period of time. In the long run, discography may cause disc height signal loss and herniations, and careful risk-benefit analysis is essential in these cases. Now, there are some mentions in the literature as well as common parlance when we are talking in a group or in meetings where people talk about discography as controversial. We must remember that the interpretation of the discogram is controversial. The act of discography is not controversial. There is a diagnostic accuracy of 85%, and the pain provocation in case of stenosis is very low, because primarily in stenosis you get more of numbness and you get more of claudication. Now, about false positive findings. Reliability of subjective concordance assessment was done in 1999, and ability of a patient to separate spinal and non-spinal causes of pain was questioned in this study. The rates of false positive in select patients without back pain, this was a study in 2000, and is low in patients with normal psychology and no chronic pain, and it correlates very well with annular disruption. So what we are saying is there is a high incidence of false positive in patients who have psychological issues, and in a normal patient there are no high false positive patients. Patients with abnormal psychological profiles have a high positive discogram than asymptomatic volunteers, and in patients with symptoms with normal psychology. Positive injections are correlated with annular disruptions, abnormal psychological tests, and chronic pain states. There was a high percentage of false positive. This was another study in 2006. Results of successful fusion in case of spondylolisthesis and patients chosen on the basis of discography for internal disc disruption. This paper says there is a higher success achieved not in discography chosen group. So indirectly what people are saying is discography may not be really detecting the pain coming from the disc very well, especially if you have fusion in your mind and you are going to choose your patient based on the study of discogram for choosing the patient for fusion. There are certain undercurrents, and these are: can discography cause long-term symptoms in previously asymptomatic patients? This was a study in 2000, and if the psychology is normal, then no. If there is abnormal psychology, then the patients are known to have some issues and some symptoms up to 1 year of the act of discography. Ability of pressure-controlled discography to predict surgical and non-surgical outcome was studied, and this was studied by Richard Derby in 1999. And if the disc is chemically sensitized, then yes, it can predict that the disc is going to be painful, and it can predict a good post-operative result or surgical or non-surgical outcome. Indirectly, we are trying to detect the inflammation, and once detected, we can predict whether it can be relieved by our treatment and how it will respond to the treatment which we are suggesting. Now, correlation of MRI and discography. MRI could not reliably predict and replace the discography. The pain in case of discography is because of chemical environment and sensitized annular nociceptors. When the annulus is sensitized, you get a distension as well as stimulation of these nociceptors, and the pain is felt. Now, study of disc morphology at post-discogram CT scan, it shows that it is complex with combinations of annular defects superimposed with degenerative annular features. Contrast leakage is associated with relief with anesthetic discogram, and who had a positive response to provoke pain in the form of provoke pain. So this was relieved if there was a leak reaching right up to the outer wall of the disc, where the lignocaine would leak through the annular tear and the patient would have relief of pain. Radial tears which were projecting into a peripheral circumferential annular tear, and if there are presence of annular flaps or annular fragments, then these also can only be seen in a CT discogram, and these are not appreciated in the normal routine discography and the fluoroscopy alone. Now here we are trying to highlight certain things. We will see that here this is a 30-year-old male with a 4-year history of increasing severe low back pain with some left leg pain and no clear history of injury. The MRI degenerative changes with asymmetric disc bulge is seen at L4-5, and discography at L4-5 we were able to inject 3 ml inside the disc, and it provokes severe and concordant back pain, and the visual analog scale was 7 out of 10. Once we injected lignocaine about 1.5 ml, then it resulted in near complete elimination of the provoked pain. Axial post-disco CT shows a wide annular gap, which is seen on the left side with these curved black arrows. In the peripheral annulus you can see the tears, and free annular fragments present in the annular gap, which is shown here, which are shown by these arrows, and then the discographic contrast leakage is positive. So what is happening in this case is the dye is leaking outside the disc, and we can see that there is a big annular tear. There are annular fragments in the annular gap. So this is a 33-year-old man, long-standing history of severe back pain for almost 3 years. MR imaging demonstrates a disc degenerative change, especially at 5.1, and discography had 2.5 ml being accepted by the disc. It provoked severe concordant pain, which is almost 10 out of 10, and intradiscal lidocaine resulted in no improvement in the provoked pain. The actual post-disco CT shows circumferential lamellar annular tear, multiple free annular fragments, and a peripheral annular tear, which is shown by the curved arrow in this picture, and without discographic contrast leakage. Now, since there is no leakage of the dye in this area, the injection of lidocaine, which we did in this patient, did not provoke relief of the pain because it was not reaching the nerve supply outside the disc. So what we have found is, if there is a leakage of the dye to the epidural space, indirectly meaning thereby that the dye is reaching the epidural space and the nerve, then injection of lidocaine would be relieving the pain, because lidocaine also would reach the nerve ending and the pain coming from the disc would stop. Then this is a patient who is a 38-year-old man with some injury about 16 years back. It progressively increased and caused severe low back pain with some radiation on the left side leg. The MRI imaging has shown a significant degenerative disc at L3-4. A discogram showed that it could accept about 3 ml inside the disc. It provoked severe 9 out of 10 pain, which was concordant at L3-4, and lidocaine resulted in no improvement in the provoked pain. Post-discogram CT images a central radial tear and a peripheral annular pocket, which is shown here in the windows, and loose annular fragments, which are shown again here by the arrowheads. Now these fragments have to come out. So a post-discogram CT central radial tear and a peripheral annular pocket is seen with loose annular fragments without contrast leakage. Therefore, because there is no leakage, injection of lignocaine did not cause any improvement of the patient narration of pain. What we have highlighted in this study, which comes from the literature, is that you need to understand there could be a post-discogram CT which will show you about the annular gaps. What has happened is our impressions about the discogram and the pictures of the disc during and after discogram are entirely based on an artist impression. Most of the clinicians don't do the discograms on their own, and therefore their interpretations are not relevant and they are not really valuable. So we need to learn, and we need to learn to interpret our discograms on our own. Now, what is development of annular gaps? Complex radial annular tears extending into the peripheral circumferential annular tears leads to detachment of fragments of the annulus, which then become free within the central nuclear region, and these are the annular gaps and the annular flaps. Alternatively, peripheral circumferential annular tear may become sufficiently detached from the outer annulus, and it develops into a sort of bucket handle tear, and this subsequently fragments and detaches, coming to lie free within the central nuclear region. So central nuclear region does have these annular gaps and the fragments of the annulus which have detached and come to lie inside the disc. Now this is a 51-year-old man with left buttock pain. This is a slide taken from American Journal of Neuroradiology, and it shows the various changes, the changes around the extraforaminal area. This is a radiculogram which we can see, and this is a 3D reconstructed image which could be now recently there is a similar technology which is called as fusion imaging, which is emerging for the assessment of patients with low back pain with a disc related cause. This is another patient which shows this tear on the periphery here. There is a leak here, and you can see there is a bulge here, and there is an extraforaminal herniation. This is a 69-year-old man with a left leg pain. So these modalities of discography and combination of discography like this and this are very helpful. The message out of all this study and talk is the whole spectrum of inflammatory sciatica and backache may be lost clinically by neglecting a simple investigation in the form of discogram, where in absence of scopy, where we do an in vivo visualization, you may be completely losing out on the changes and the chemical changes which are essentially the basis of causing the pain. We also fail to correlate the pain and these changes, and we only depend on use of heavy metal for fusing the spine, which is not really correct. We so have not been able to do simple things like staging the sciatica and understand the subsets, because all our attention has been on the images in the form of non-invasive images primarily, and then of course these invasive images. So what we do is, it is better if we arise to the concerns of the patient. The patient comes to us with pain. The patient wants a clear-cut answer. Where is the pain coming from? We need to also understand our target of our treatment. So this is the best way to come out with a better and precise solution. Thank you very much. Have a good day.